I'm going to talk to you today about utilization of PET in breast cancer. Again, I have no disclosures. Okay, so we're going to look at PET in initial staging of breast cancer, whether or not it's useful. And then we're going to look at PET in detecting distant metastases in breast cancer. We're going to look at detecting recurrence, how useful it is, assessing response to chemotherapy and neoadjuvant chemotherapy, which is used very frequently today in breast-conserving surgery. And very briefly, I'm going to touch on non-FDG PET tracers for breast cancer workup. This is mainly an FDG PET talk, and I'm not really going to go in detail to other breast PET tracers. Okay, so the appropriate interpretation of PET-CT requires a sharp knowledge of potential false negatives. They might result from small tumor size due to partial volume effect or low FDG uptake. And the main factors influencing tumoral uptake are tumor grade. Its grading system, grades 1 or 2 tumors show lower FDG uptake than grade 2 tumors. Histologic subtype, carcinoma in situ versus more invasive tumors, the proliferation index, P53 status, stuff like that. So anatomic size is really, really important. Nodal status is important. Whether or not a patient has distant metastases. These are the criteria that AJCC's newest edition based their staging on. And the prognostic stage included the tumor grade, whether or not the hormone receptor status, whether or not it was estrogen receptor or progesterone receptor positive, oncogene expression, and the results of multi-gene panel testing. All of these factored into the staging of the tumor. One of the changes in AJCC, the 8th edition, was the breast cancer staging. Lobular carcinoma in situ was no longer included as carcinoma in situ category, but was rather considered as a benign entity that may indicate a higher risk of future breast cancer. So again, like every other tumor, this is also based on TNM, staging system, whereas tumor size greater than or equal to 2 centimeters, between 2 to 5 centimeters, greater than 5 centimeters, these all factor into the T stage. N stage, whether or not there is lymph node involvement, how many lymph nodes? Are there more than one lymph nodes, which really does affect our sensitivity in PET, or is it just one lymph node? And of course, distant metastases. So the staging was, again, all the way up to stage 2B was less than 5 centimeter tumor with maybe one lymph node involvement. Stage 3A, this was stage 2B, forgive me. Stage 3A stated those stages where the tumor was either between 2 to 5 centimeters or greater than 5 centimeters, but definitely required more than 2 lymph nodes. If there was 1 lymph node, then the primary tumor had to be greater than 5 centimeters. So a lot more aggressive features. Either the tumor itself had to be more than 5 centimeters, or there needed to be more than 2 lymph nodes involved. So that was stage 3A, at which point, why am I highlighting this? At which point PET-CT imaging after neoadjuvant chemotherapy or PET-CT imaging in staging the patient was deemed useful. Before that, PET-CT imaging clinically is not, and the studies show that it was not useful.